Bueno, hola a todos y a todas las asistentes. Mi nombre es Andrés Fresno y a nombre de la Universidad del Desarrollo y la Universidad de Talca quiero darles la bienvenida al encuentro internacional El rol de la regulación emocional en la salud mental, perspectivas básicas y aplicadas. Los invitamos a participar en esta actividad realizando sus preguntas a lo largo de ella en la sección Preguntas que está en la barra inferior de Zoom. Les pedimos que el chat lo usen solo en caso de problemas técnicos y otras interacciones con el panelista. Finalmente comentar que esto es una actividad que está siendo transmitida a través del canal de streaming de la Universidad del Desarrollo, ¿sí? Que es uddtv.udd.cl. Y durante los próximos días dejaremos disponibles los videos de las actividades autorizadas por los expositores en el sitio web de cada facultad. Para seleccionar la interpretación simultánea, deben seleccionar el icono de globo terráqueo que encontrarán en la barra inferior de su panel de Zoom. Al pinchar, deben seleccionar el idioma en que quieren escuchar toda la actividad, sin importar en qué idioma hable el expositor. De todas formas, estaremos pendientes al chat por cualquier problema o ayuda que necesiten. To select simultaneous interpretation, you must select the globe icon that you will find in the bottom bar of your Zoom panel. You must select the language in which they want to hear the entire activity, regardless of which language the exhibitor speaks. We will be waiting to chat for any problem or help you need. Esperamos que hoy la tecnología y las conexiones nos acompañen, pero les pedimos consideración si es que tuviéramos algún problema técnico durante la charla, ¿sí? Agradecemos a todos los profesionales y estudiantes interesados en participar en estas actividades. A continuación, escucharemos la conferencia titulada Manejando las dificultades de la regulación emocional en personas con estrés postraumático complejo. Esta presentación está a cargo del doctor Jonathan Bison. El doctor Bison es uno de los referentes internacionales en el estudio del tratamiento del estrés traumático. Él es profesor de psiquiatría de la Facultad de Medicina de la Universidad de Cardiff. Es director del Centro de Estrés Traumático y Salud de Gales y subdirector del Centro Nacional de Salud Mental de Gales. Ha realizado numerosas publicaciones e investigaciones, incluidos 6 ensayos controlados aleatorios y 5 revisiones sistemáticas Cochrane que han dado forma a la investigación y a la práctica en el campo del estrés traumático. Fue presidente del Comité de la Sociedad Internacional de Estudio de Estrés Traumático para el desarrollo de las guías clínicas para la prevención y tratamiento del trastorno de estrés postraumático, que han sido publicadas recientemente. Además, es director del Grupo de Investigación sobre Estrés Traumático de la Universidad de Cardiff. El doctor Bison forma parte del grupo de expertos detrás del trastorno de estrés postraumático complejo, incluido recientemente en la CIE 11. Y junto a su equipo trabajan en el desarrollo de la entrevista estandarizada para evaluar este trastorno, cuya adaptación al español desarrolla en colaboración con el equipo de trauma de la Facultad de Psicología de la Universidad de Talca. Doctor Bison, estamos muy contentos de tenerlo hoy aquí con nosotros.
Yeah, thank you very much, Andrés, and gracias por invitarme. Estoy muy contento de poder hablar en la conferencia, pero desfortunadamente necesito que hable en inglés. So from now on, I'm going to speak in English. I'll just share my screen with you now so that you can see my slides properly. So hopefully everybody can see my slides now. Please do let me know if not. So what I'm going to talk about is managing emotional regulation difficulties in people with complex post-traumatic stress disorder. I'm sure that most of you will be familiar with the fact that the International Classification of Diseases, the 11th edition, which has now been published, but will only become official in most countries in a year or so down the line, has introduced a new diagnosis for people affected by traumatic events called complex post-traumatic stress disorder. And the key difference between post-traumatic stress disorder and complex post-traumatic stress disorder is that in complex post-traumatic stress disorder, in addition to having been exposed to a traumatic event that actually causes or threatens death, serious injury, or sexual violence, you also have to have the symptoms of re-experiencing, avoidance, and hyperarousal that we are all very familiar with post-traumatic stress disorder. But with complex post-traumatic stress disorder, additionally, we have these disturbances in self-organization. So these are symptoms that include emotional regulation difficulties, either hyperactivation, so in other words, becoming very emotionally aroused, if you like, and having difficulties calming down, or deactivation, kind of feeling numbed, dissociated, cutting off. Clearly, both of these things can be seen as kind of a defense around dealing with one's emotions. Negative self-concept is another cluster of symptoms that come into this disturbances in self-organization group, with feelings of being diminished, defeated, worthless, shame, guilt, and despair, all being particularly common features of the negative self-concept that people with complex PTSD experience. And then finally, disturbances in relationships, so persistent difficulties in feeling close with little interest in relationships or social engagement. So the best way I find of thinking of complex post-traumatic stress disorder is that you need the criteria for PTSD plus at least one of emotional regulation difficulty, negative self-concept, and disturbed relationships. As Andres mentioned, the International Society for Traumatic Stress Studies published its guidelines for the treatment of post-traumatic stress disorder a couple of years ago in 2018, the end of 2018. And at that time, and the same is still true, there was plenty of evidence to develop these recommendations for the prevention and treatment of post-traumatic stress disorder, but there was much less information when it comes to making recommendations for the treatment of complex post-traumatic stress disorder. Not surprisingly in many ways, because it's a very new diagnosis. Until the emergence of ICD-11, there was no possibility of diagnosing complex PTSD, although clearly a lot of us working in the field would talk about people with more complex presentations of PTSD. So what we decided to do within the ISTSS was, rather than make recommendations for the treatment of complex PTSD, was to develop position papers for both adults and for children and adolescents. And certainly for those of you who are interested in the field, I'd recommend that you have a look at those, and they kind of give you an update as to where we are at the moment, give some recommendations as to what might be evidence-informed, if you like, treatment, rather than necessarily evidence-based treatment, and also give some direction for the future. Thankfully, since 2018, there's been quite a lot of work actually to look at what may or may not work for the treatment of complex post-traumatic stress disorder. And, you know, in terms of today's talk, not least emotional regulation difficulties. There have been two major systematic reviews that have been conducted, and, you know, I certainly didn't lead either of them, but was fortunate enough to be part of them both. And the first one was this one, which was published in 2020 by Peter Coventry and colleagues. And this was a systematic review that was really looking at the type of issues that people experienced following complex traumatic events. So interestingly, rather than looking at a diagnosis, this one looked at the nature of the events rather than the diagnosis. The other systematic review I'm going to talk about looked at the symptoms rather than the nature of the traumatic event. So fortunately, we've got evidence from both sides to try and consider this. So this review looked at both psychological and pharmacological interventions. They looked at randomized controlled trials and non-randomized controlled trials published until October 2019, and looked at individuals exposed to complex traumatic events. And we can go on to discuss that a little bit more. PTSD symptom reduction was the primary outcome. So really those symptoms of re-experiencing avoidance, hyperarousal, perhaps, sort of DSM-5 configurations of PTSD. So including things like negative appraisals and cognitions related to a traumatic event too. 116 randomized controlled trials and non-randomized controlled trials were found, and of these, 94 of them could be included in the meta-analyses that were undertaken. What Coventry and colleagues did was that they also did some component network meta-analyses. I'm not sure how familiar you will be with these, but these kind of look at, they try and link into a network different studies that have been undertaken, even though they've not directly compared one treatment with another. So it gives you some sort of a feel of the relative efficacy of different treatments, even though they haven't been compared in a head-to-head manner. The mean age of the people in these studies was just over 42 years old, and 58% of participants were female in the studies. I think it's really important to remember this, and this is kind of true for all PTSD, complex PTSD research, is that there's an overrepresentation of people with PTSD and complex PTSD to military combat. So almost half of the people involved in these studies had their PTSD, complex PTSD, to military traumas, 13% to childhood sexual abuse. I mean, if I think of my practice in the United Kingdom, then well over 50% of the people that I would see with what I would diagnose as complex post-traumatic stress disorder, childhood sexual abuse plays a major role in that presentation that they have. Of course, the other thing to remember is with more complex presentations, individuals are often exposed to a range of different traumatic events. So the typical sort of traumatic events would include things like any form of abuse during childhood, domestic violence, repeated domestic violence. Military trauma would be another one that's commonly agreed to be a complex traumatic event for people to experience. And then refugees and asylum seekers are another group of individuals who are often exposed to more complex traumatic events. A variety of them, including things like trauma. In the studies that we've done in the United Kingdom, then the mean number of traumatic events experienced by people is over 6. So in other words, people are not presenting with PTSD or complex PTSD to a single traumatic event, it's to a number of different events. The mean follow-up following treatment in these studies was 11.5 weeks. And I think that's important to remember. That's not a very long follow-up period. So clearly more research is needed to determine whether people continue with their improvements, if you like, for much longer than just 3 months after they completed their treatment. And the other thing that interested me about this study was that the duration of treatment in total was only 7 to 18 hours. So if you think about it, for people with very complex presentations, we will often engage them in treatments that are much longer than 18 hours. But these randomized controlled trials were all of treatments that lasted a maximum of 18 hours duration. 51 psychological treatment randomized controlled trials were included in the meta-analyses. So again, just to remember, the 116 studies were included initially, and the data that could be analysed to answer the key question that we've got, which is around, do psychological treatments help to reduce emotional regulation difficulties? Only 51 studies could be included in these analyses. So this shows you the results, and this is looking at standardised mean difference for PTSD symptoms. These are continuous scales, so scales like the CAPS, the clinician-administered post-traumatic stress disorder scale, which give a range of different scores. The higher your score, the more severe your overall PTSD symptoms are felt to be. And what I've done here is I've shown you little bars for everybody included, and then the red bars just represent veterans in these studies. After each treatment, I've put a little bracket with a number in it, and that number represents the number of studies that were included in this particular meta-analysis. So for eye movement desensitization and reprocessing, there were 9 studies, and for people overall, they did very well with it. The effect size, the standardized mean difference, was almost 1. And my general way of sort of thinking about effect sizes, well, mine, sort of the world's really, is that an effect size of less than 0.5 is considered a relatively small effect size. Between 0.5 and 0.8, a moderate one, and above 0.8 is a strong one. So 1 is a very good effect size. And if you look at the, these are obviously treatments of people exposed to complex traumatic events. But if you looked at a similar analysis with people with post-traumatic stress disorder to any traumatic event, that would probably go up to about 1.2, 1.4. So you would get a slightly increased rate of improvement or higher level of improvement, but nevertheless, this isn't far off for people exposed to more complex traumatic events. As you can see, for both EMDR and trauma-focused CBT, the veterans tended to do significantly worse than all populations, although nevertheless still had statistically significant benefits from receiving the treatments that they received. Even though there's mild differences, I don't think we can really argue there's a great difference between EMDR and cognitive behavioral therapy with a trauma focus there. It's important to say that there's a lot more studies, 3 times the number of studies have looked at trauma focused or CBT with a trauma focus than they have with EMDR. For non-trauma focused CBT, A, only 3 studies have been done in these populations, and B, the results are very disappointing, really. There's almost there's almost no difference there between receiving non-trauma focused CBT and being left on a waiting list or receiving usual care. So we can't really recommend non-trauma focused CBT for this group. The same is true for mindfulness, unfortunately, although we're seeing small but positive gains here. All the studies were done in veterans. There have only been 3 studies, and that asterisk there represents a non-statistically significant change. Even for interpersonal therapy, that's true, although you can see the possibility of a much greater improvement appeared to be true there. But the fact that there were only very few studies meant that the confidence in the accuracy of that result is very limited for us. So the bottom line from Coventry and colleagues' study was that EMDR and CBT with a trauma focus should be the treatments that we're favouring for people exposed to complex traumatic events if we want to reduce their PTSD symptoms. Thinking about other symptoms, well, if you look at PTSD symptoms overall, when you group everything together, so all the different treatment modalities together, actually you get greater improvements for depression and anxiety than you do for PTSD. Here, the red bar isn't veterans, it's actually using an active control as opposed to an inactive control for the waiting list. So not surprisingly, if you compare, for example, cognitive behavioral therapy with a trauma focus to relaxation training, you're going to get a lower effect size, or you would expect to get a lower effect size than if you compare it to a waiting list control condition. Quality of life, interestingly, didn't come out as being statistically significant, a bit of a trend to improvement, but not statistically significantly different. And I think that does raise some questions and should do in our minds. If we're getting symptom improvement in people, why aren't we helping people to feel that their quality of life is improved? I think there's perhaps a couple of reasons for that. One is that not every study measured quality of life, so we might be getting an artifactual finding as a result of that. And then the second one is that I think often quality of life, there's a bit of a delay between getting your symptoms improved to your quality of life improving. So for example, if I'm depressed and I'm not working as a result of my depression, and I lose my depression and I feel able to work, I've then got to get a job, get myself established in the job before perhaps I feel the benefits of working again coming through. And just to give you some perspective, in these systematic reviews, both antipsychotic drugs and praxisine also showed good benefits, and this is looking at PTSD symptoms, an effect size of about 0.5. So small but positive benefits. So, you know, and people that have heard me speak before will know that my belief is that medication pharmacological approaches are also going to play a significant role for a lot of people presenting with complex difficulties following traumatic events, of which clearly complex post-traumatic stress disorder is the one that I'm trying to focus on more than anything else today and do in my practice, I guess. So the conclusions of Coventry and colleagues were that for disturbances in self-organization, these symptoms peculiar to complex PTSD, cognitive behavioral therapy with a trauma focus is the most effective for negative self-concept. Phase-based learning is a leading candidate for interpersonal problems. And what they found, unfortunately for us for today, was that there was no proven effective intervention for emotional dysregulation. So very few of the studies actually used outcomes that would help us with that. Only a few actually looked at direct measures of emotional regulation, and those that did couldn't really, we can't really draw any good conclusions from them. So what they recommended was to use trauma-focused psychological treatments, either EMDR or trauma or CBT with a trauma focus, and also skills-based strategies, which I'll come on to in a flexible manner, and that it's important to think beyond PTSD alone. I mean, the other thing I should have said when I'm talking about the typical people that we work with have at least 6 or have a mean of 6 traumatic events that they're dealing with. They also have a mean of about 3 or 4 different psychiatric disorders at any one time. We're not talking about a single condition, complex PTSD or PTSD on its own. We're talking at people with multiple morbidities. And thrown into that, you've often got, in addition to mental health morbidities, you've got physical health morbidities as well. The second meta-analysis was led by Thanos Karatsias, and this one looked at psychological interventions for ICD-11 complex PTSD symptoms. So in a way, this one's even more focused on what we're trying to think about today, which is how to treat emotional regulation difficulties in the context of complex post-traumatic stress disorder. Karatsias and colleagues looked at all randomized controlled trials published until January 2018. They were psychological interventions only in this review, and post-traumatic stress disorder with likely clinically significant baseline disturbances in self-organization was required before you could actually be included in the trial. So just having PTSD, you would have been excluded even though you had been exposed to a very complex trauma. Likewise, if you were exposed to a simpler trauma, say a one-off road traffic accident, if you were describing negative self-concept, emotional regulation difficulties, or interpersonal relationship difficulties, you would have been included in this meta-analysis. So there are 51 randomized controlled trials included in this work. There's a degree of overlap with the Coventry study, but there's also several studies that weren't included in the Coventry meta-analyses. And what Thanos Karatsias and colleagues did was to look at both PTSD and DSO symptoms, the reductions in those symptoms as their primary outcomes. So again, this is a bar chart showing you the improvement, and this is looking at improvement in different types of symptoms according to whether you receive cognitive behavioral therapy, well, trauma-focused cognitive behavioral therapy interventions, exposure-only interventions. So this is thinking of techniques that would be very much like, Edna Foer's prolonged exposure manuals, that sort of treatment, without any real focus on using cognitive techniques to help with symptoms. And then the third group would be eye movement desensitization and reprocessing, so the one in green. So again, you can see that for cognitive behavioral therapy with a trauma focus, a lot more studies, 27 studies looked at PTSD symptoms, 6 for exposure only, and 4 for EMDR. So the confidence in our results we have for CBT with a trauma focus is much greater than either for exposure alone or for EMDR. Now, interestingly, in this, we can see that really the CBT and the exposure, which I would class as a CBT, seem to do a little bit better than EMDR overall when it comes to reducing PTSD symptoms, although, you know, clearly there's good improvements for all 3 of those there. When it comes to disturbances in relationships, interestingly, EMDR seemed to do better than the CBT and the exposure, although very much within sort of confidence intervals to say there's no real difference. With affect dysregulation as well, only 1 study for EMDR, although it was a very good outcome, and only 3 studies looked at affect dysregulation for cognitive behavioral therapy. So, you know, an immediate take-home message from my talk really is that when it comes to looking at evidence for what I'm meant to be talking about, there isn't an awful lot of it around. There's been very few randomized controlled trials that have even measured affect dysregulation as one of the main outcome measures of this study. Now, that's not to say, of course, that for the other 24 studies here, that if they had measured affect dysregulation, they wouldn't have got good improvements. We just don't know the answer to that. Certainly anecdotally and from my own personal clinical practice, I think that you do see good emotional regulation in a lot of people that you successfully treat with complex difficulties, you know, of a complex PTSD nature with CBT, with a trauma focus, and with EMDR come to that. For negative self-concept, again, you know, some evidence of improvements. And when you look at sort of a hybrid where you try and combine both PTSD and DSO symptoms together, you know, all 3 came out well. And in fact, EMDR, you know, looks as if it's doing even better there than the others, but all had effect sizes of greater than 0.8. So even though this work of Karatsias et al., none of these studies said you've got to have complex PTSD to be included because it wasn't a diagnosis when the studies were done. Just looking for the characteristic symptoms of complex PTSD, we've got good evidence that CBT with a trauma focus, exposure work, and EMDR can all be helpful to people with that presentation. Mindfulness and interpersonal therapy also showed promising results, but very few studies for either of those, which is why I haven't got them on the graph there. And then just to let you know, things to take into account when you're interpreting what I've just shown you. If you received usual care, you tended to do worse than if you received a waiting list control. So that's an important one to remember. The quality of the study, interestingly, the worse the quality of the study here, the worse the outcome of the study. To be honest, it's often the other way round, but in this meta-analysis, the worse the quality, the worse the outcome. And also, if your traumatic events started in childhood, you tended, unfortunately, to have a poorer prognosis than if you were reporting adult-only traumatic events. So all things for us to consider. And they also found that it wasn't possible with the number of studies that looked at this to address whether phased was better than not phasing treatments, or vice versa. And so, again, we'll come on to discuss that in a bit more detail, but that's an important take-home message as well, that there just isn't evidence at the moment to say whether to phase things or not to phase things. So a phased approach is something that I do like quite a lot, actually, in my treatment of people presenting with complex PTSD. And what a phased approach says, really, is that we should initially try and stabilize people before we move into a more trauma-focused therapy approach. For some people, they will come into us undoubtedly already stable enough to go straight into a trauma-focused therapy. But if people aren't stable, I would tend to spend some time doing some stabilization, even though, as I've just said, there isn't direct evidence either way for that. But clearly, you know, thinking of a hierarchy of needs, if people have physical difficulties, accommodation difficulties, financial difficulties, they haven't got access to good food, then those are usually things that we would want to address first before engaging in some form of psychological treatment. And likewise, emotional stabilization, helping people to be on a level emotionally where they can tolerate and focus on some of the treatments we're going to be doing with people, which, let's face it, aren't always the easiest things to engage in and to do. People need to be very focused on them and in a stable situation, in my experience, to get the most out of them. And clearly, emotional stabilization often involves social factors, psychological factors, and pharmacological factors. And what we'll be doing is focusing more on the psychological factors today. The phased approach really says that once you stabilize people, you can do trauma-focused therapy. And then once people complete their trauma-focused therapy, you then help them to integrate into a new situation. So, for example, refugees, asylum seekers, who this approach was sort of developed for initially, then integration might be into a new community, into a new environment, a new country, for example. I see a lot of people, who've been subjected to repeated domestic violence. And clearly integration to living without, not being in a domestically violent relationship, often new accommodation circumstances are clearly things that people need to integrate with to move forward. And, going back to what I was saying before, maybe gain an improved quality of life moving forward in the future. So there are different ways of trying to stabilize people, but one of the models that I like a lot is this one that was developed by Marilyn Cloyter and colleagues going back to the early 2000s, 2002. This book was published and then it was updated in 2020. And certainly for those of you who are treating survivors of childhood abuse and interpersonal trauma, I think it's a good book to have on your bookshelf. It's full of very useful hints and tips. Yeah, I do work with Marilyn, but I don't have any conflicts in terms of recommending that people buy a book, by the way. So this book really argues that initially people benefit from having 8 one-hour sessions of skills training in affect, so emotional and interpersonal relationship skills. And so the start of it is not trauma focused at all. It's very much giving people skills. The argument being that for people who have been abused during their childhoods, they've not had the opportunity to learn some of those basic skills that we often take for granted if we've had a good nurturing during our childhood. I also think actually that this applies to people who have had good nurturing in their childhood, but have maybe forgotten some skills or been put in situations that challenge some of those skills that they've learned. Again, thinking of people who've been exposed to perhaps military trauma, domestic violence, refugees, asylum seeker experiences in adult life. And it's important to say that even though I'm talking about limited evidence for a phased approach, there's good randomized controlled trial evidence that this does help people. So this is what we call a forest plot, which shows you all of the randomized controlled trials that have been done for cognitive behavioral therapy with a trauma focus when it comes to looking at developing the evidence base to recommend it for post-traumatic stress disorder. And here you can see where my arrow is, Cloyter 2002. And if we follow that line across, you can see a horizontal line there, which is well to the left of the vertical bar, which means that it was clinically and statistically significant in that trial that people that received stair therapy, followed by modified prolonged exposure, did better than people who received a waiting list intervention and then had their treatments at a later date. So what is enhanced skills training in affective and interpersonal regulation? Well, this is a treatment that's been developed specifically for ICD-11 complex PTSD. It builds on that work that Marilyn Cloyter did, and Marilyn is one of the key authors of this work as well, and looks at trying to deal with the 3 clusters of disturbances in self-organization, so negative self-concept, emotional regulation difficulties, and interpersonal relationship difficulties, as well as symptoms of PTSD. There's an initial 1-hour formulation session followed by 6 sessions for each of the 4 different symptom clusters that I've just mentioned. So PTSD gets 6 sessions, and then the 3 DSO clusters get 6 sessions. And one of the ideas in this is that you can phase it according to what that individual's needs are. So if an individual presents with more interpersonal relationship difficulties, you might want to start off with the interpersonal relationship module. If they present more with emotional regulation difficulties, you may want to start with that. If they have no negative self-concept, you may get rid of that one from your treatment package and end up with 3 modules of 6 sessions each. So you end up with 19 sessions rather than a 25 session intervention. So this is clearly moving much more towards a personalized approach to the treatment of people with complex PTSD, which I think is to be greatly welcomed. So skills training in affective and interpersonal regulation is derived from generic CBT, but also from dialectic behavior therapy. And those of you who are familiar with that for borderline personality disorder will recognize some of the components in that when you go through the STAIR sort of work. The idea is to create or develop emotional awareness, provide people with skills to regulate their emotions, and also to learn how patterns learned in early relationships to continue to guide current relationships and how to use emotion regulation skills in relationships. So from that, it's very apparent that I think that emotional regulation and experiencing good interpersonal relationships are very interlinked together. You know, they go hand in hand. So with the skills training, what we're trying to do is to help people to label and identify their feelings, to manage their emotions, to be able to tolerate distress a bit more. I mean, clearly that's a big issue for people with complex PTSD with emotional regulation difficulties, that tolerating distress is very difficult. I mean, a minor upset can lead to a catastrophic reaction that's very difficult to control. Accepting feelings for what they are. You know, we all have feelings that we accept and we don't act on them. And actually, to contain feelings is part of, you know, managing our emotions as human beings. And then also identifying trauma-based interpersonal schemas. So looking at why you might be reacting to people in positions of authority, for example, in a particular way, when you remember how you had to react to that person in authority who was abusing you, perhaps as a child. And so role players of power, control, and flexibility are all key to this. Yeah. So a great piece of work that I've been involved in the last few years has been working with colleagues at Talca University and developing a cognitive behavioral therapy with a trauma focus treatment for post-traumatic stress disorder. And I'm really pleased to say that, you know, Andres Fresno, Rosario Spencer, Nadia Ramos, and Carolina Salgado have now all successfully treated people with complex presentations with using this manualized approach. Daniel did an awful lot of very positive work at the start of our work on this as well. So this is a really positive collaboration, I think, between Chile and Wales, which is where I'm from. So one of the things that we determined when we were developing this work was that it was really important to try and do some work on emotional regulation, thinking of the average person, if you like, with PTSD or complex PTSD, who's going to be presenting to treatment services in Chile. And so we actually, with the help and support of Marilyn Cloyter, adapted some of the modules from the STAIR manual into this Cardiff University, Talca University manual. And what I'm going to do is to just give you some examples of what we do from this. So there are the 3 channel experience of emotions is something that we try and get across to people. So if you think of your emotions, there's sort of bodily experiences, thought experiences, and behavioral experiences. So a scenario might be that you're standing in a queue, a line to buy some shopping, and then a man pushes in front of you. How does that make you feel? Well, you might feel very tense, you clench your hands, you've got shallow breath, you're over breathing and your heart's beating quickly, and you might think, Who does he think he is? That's unfair. Does he think I will let him get away with it? And your behavior might be to shout, to ask him go to the back of the line, do nothing, or unhelpfully ruminate on the situation. And obviously these thoughts and behaviors and the bodily feelings are very, very common in us all. And most of us, if we want to deal with these sorts of things in an appropriate manner, will learn a way of adapting our behavior in a way that's going to achieve an outcome that A, is satisfactory, and B, doesn't cause us too much ongoing distress in the future. So we try and help people develop a range of different tools that they can regulate their emotions with. And these, again, come across the different channels. So for your body, we try and help people to develop focused breathing, so controlled breathing, grounding techniques to actually help themselves, ground themselves to reality rather than getting detached or dissociated or off with an experience and losing control with it, and also basic relaxation techniques. So there's definitely nothing rocket sciencey about here. And I think all of these techniques are things that you're likely to be using very commonly anyway. We use quite standard cognitive techniques to challenge some of the distorted patterns of thinking, the evidence techniques, so looking at what you think, what alternative thoughts there are. We try and help people shift away from unhelpful thoughts and use positive imagery to help them feel a bit calmer as they experience their thoughts, rather than perhaps in a knee-jerk way acting on them straight away. And saying positive self-statements is another thing that can be very helpful. Emotion surfing, I guess, is kind of like a mindfulness technique to help you to let thoughts flow rather than, again, getting preoccupied with them and having to act on them straight away. And hopefully we can work with people to help them develop alternative behaviors. So, for example, slow down, take a break, consider alternative activities, think of the opposite action to the immediate one that you're thinking of doing, and also seeking support of other people. Thinking about emotions and feelings as a messenger is another key component in dealing with emotional regulation difficulties. So thinking of emotions and feelings as having a purpose to keep us safe, to help us guide our decisions and actions, tell us who we are, for example, our likes and dislikes, enabling us to communicate effectively with other people. If we feel angry or sad about something, it's probably giving us a signal as to some of the actions we might be taking, but hopefully we can come up with an adjusted way of, I guess, sort of articulating those emotions to other people. Negative emotions, feelings can also be helpful. So depression, even though it's an unpleasant experience, it can help us to motivate change in an area of life. People can get very depressed in a relationship and yet remain in a relationship that isn't going anywhere for that individual for years. And actually, by acting on that in a well thought out manner and removing oneself from a depressing relationship can actually help a lot of people to get on, with their lives better than they would have done if they'd have stayed in it. And it can also be used to support behavior, for example, treating others kindly, living more healthily, are all things that our emotions and feelings can be good for. The guilt about certain things that we eat or drink can be quite helpful in measuring our impulses to do certain things. We use these sort of self-monitoring of feelings forms, which again, I'm sure that a lot of you will be familiar with through some of the other work you do. So, for example, just taking the example that I just gave, somebody, a patient that we're seeing may report feeling sad, 7 out of 10 in terms of intensity, because a man pushed into the queue. The thoughts could be, people walk all over me, and the person reports having got very angry, shouted at the man and walked out of the shop. Whereas clearly that's not an adaptive way of responding to that situation. I mean, it might feel better just for a very brief second, but A, you've got to deal with having shouted at that person, and B, you probably haven't got the milk that you went into the shop for, which isn't exactly a constructive solution. So what we would do is we would practice with the individual ways of perhaps challenging that way of thinking and perhaps coming up with a different response, like politely asking the man in an assertive manner to go to the back of the queue and seeing where that gets to. And we often, during the therapy, practice these in role plays. So, for example, I would ask a patient to show me what happened, and I would pretend to be the man. And then I would ask the patient to pretend to be the man, and then I would show them what I would do if that happened to me, and try and help the individual to learn different types of behavior and then model their own behaviors on that. A lot of people with complex post-traumatic stress disorder have great difficulties naming their emotions and feelings. So they have difficulty thinking of words like ashamed, empty, bored, tired, humiliated, despairing. And things like this feelings wheel, it's almost like a dictionary, a lexicon of different words that people can then use and look at and think, does that relate to me? And it's trying to help people recognize things more in themselves, perhaps things that they don't really recognize and have never truly thought about. We also try and help people to identify and challenge negative thoughts. And I won't go through all of these, conscious of time as much as anything, but we give people handouts that have common negative thoughts. I am a failure. I am not likable. The world is not safe. And clearly, by having a piece of paper or a digital version of that, people can see that they're not on their own. And they try and we encourage people to use these thoughts to validate the way that they're feeling and to normalize those, as well as identifying some patterns that they're getting into. And then clearly through that, we can then identify thoughts that may need to be challenged in terms of our cognitive work with the individual to help them, shift the way that they think and feel less distressed by things. So clearly using things like positive imagery can be a really good way to help people tune out of negative ways of thinking and tune into more positive ways of thinking. And, we give people handouts and we discuss with them these different sort of techniques that can be helpful. Other handouts are things about positive self-statements, so making mistakes is being human. Excellence doesn't require perfection. I mean, I often ask people to write that down on a piece of paper and put it on their fridge so that when they open the fridge every morning, they remind themselves that actually it's normal to make mistakes if one's human, and being excellent doesn't require perfection. And perhaps that helps the more obsessional person, perhaps, to challenge some of their thinking in a better way. And then we have handouts on things like emotional surfing as well. So getting towards the end of what I was going to say now, another one about just unhealthy behaviors, so trying to avoid using substances, overeating, gambling, etc., etc. All of these things I think can be very helpful aid memoirs to people with emotional regulation difficulties. So to sum up, then, what I would always recommend with somebody with a complex presentation of PTSD is to do a full biopsychosocial assessment. I think a good assessment is really vital, for everyone really, but the more complex, the more important it is. Treatment often involves a greater diversity of interventions than a simpler form of condition, often requires longer duration. We're often talking 16, 24 sessions for people. A personalized approach, and I'm sure that colleagues in Chile will be able to reflect on experiences with people and how they very skillfully change tack a bit to personalize a treatment towards that individual, using not only techniques that we've got in our manual, but also going outside the manual as well. It's really important to involve different agencies and different disciplines as required, and to co-produce a management plan with the individual. So the person with complex PTSD, if they're part of developing a management plan that's sensible for them, I think it's got a much better chance of success. So phased approach, again, that's debated. I'm quite a fan of it, if I'm absolutely honest, but more work is needed to determine whether it is required or not. Just to say thank you to the research group that I work with closely with, and thank you very much for your attention.
Thank you very much, John, for your interesting presentation. Muchas gracias, John, por esta presentación tan interesante que da una visión global sobre la regulación emocional y el trastorno de estrés postraumático complejo y las distintas intervenciones que cuentan con evidencia hasta este momento para abordar los componentes relacionados con regulación emocional en este tipo de trastorno. Muchas gracias, John. Ahora vamos a pasar a la ronda de preguntas. Tenemos un poco de tiempo. Y quisiera primero que nada agradecer las preguntas muy interesantes que han hecho durante la conferencia. La primera pregunta que quiero realizar es relacionada con la situación de pandemia, ¿sí? Y Cibeles pregunta si durante la situación de pandemia ha habido un aumento del trastorno de estrés postraumático en el personal de salud, en los profesionales que trabajan en salud, en el sistema de salud.
Yes, the answer is definitely yes to that. I mean, if you look at the global population studies that have been done, and there's lots of them coming out now, as a caveat, I have to say that a lot of them, it's very difficult to argue that they are truly representative of the population that they're studying. So I think we're probably getting overestimates coming in at the moment. But the better studies are showing an increase of perhaps 10–15% in overall rates of PTSD amongst the population as a whole to the pandemic, but with much greater increases in individuals directly exposed to traumatic events. There have been some studies of healthcare workers that show prevalence rates of between 20 and 30% to the pandemic for those directly involved in it. And a recently published study in the United Kingdom showed that of those individuals working in critical care, so right at the sharp end, if you like, of health treatment for people affected by the pandemic and dealing with a lot of people who are dying or died, then PTSD rates of around 40% to that experience. I think we need to wait a bit longer to find out exactly what the percentages are. I'm certainly now treating several healthcare professionals with post-traumatic stress disorder directly related to the pandemic.
Ok, gracias. La siguiente pregunta se refiere a el abordaje de la comorbilidad, ¿sí? Respecto a la regulación emocional y las intervenciones terapéuticas. ¿Cómo debe abordarse la comorbilidad en tratamientos de trastorno de estrés postraumático simple o complejo? ¿Se debe abordar en paralelo, antes o después?
Yeah, so for comorbidity, I think is the issue here. So if an individual has got complex PTSD with another condition, then as I said, that's usual, that's the norm. And my judgment is always to look at what the primary issue is that the individual has, and then I tend to treat that first. Clearly, with a lot of conditions, be it complex PTSD, depression, substance use disorders, whatever, then often trying to achieve a degree of stabilization is going to be very important, irrespective of the diagnosis. So you can almost take a transdiagnostic approach to that. And if somebody has just not got stabilization, whatever their condition is, I would focus on stabilization. If, for example, somebody has got a substance use disorder that is out of control, then I would be probably trying to help them reduce and come off their substances, or at least bring them under control before starting on, certainly more trauma-focused work for their PTSD. So again, I think this question underlines the importance of a good assessment, and then personalizing the treatment according to that individual's needs.
Okay. Otra pregunta tenía que ver con, en tu opinión, ¿cuál es la relación entre pacientes que tienen trastorno de estrés postraumático complejo y las características de la familia, ¿sí? ¿Existe alguna relación entre estos pacientes y familias multiproblemáticas?
Yes, I mean, definitely. So when we talk about post-traumatic stress disorder, we're often thinking of, traumatic events that involve, sort of serious injury, death, or sexual violence. But actually, when, all of which are highly traumatic, of course, but when I'm seeing people, some of the people who I think are most difficult to treat and have the biggest problems are people who've had emotionally neglected childhoods. So emotional neglect during childhood, I think, really does impact on people massively. And they are often actually the key individuals who I think can benefit an awful lot from skills training, because with emotional neglect, you're often getting very limited input to learn basic skills in terms of regulating emotions, relating to other people. You're often landed, if you like, with a negative self-concept. So all of these modules around stabilization and the disturbances in self-organization come out very strongly. I think also, if you're in an environment where you have a relationship with somebody which is negative in an ongoing manner, and I think we see this both with people who've got parents who, perhaps in their adulthood, I see 50-year-olds who are still sort of kind of very influenced by their parents in a negative manner. And it's clearly important for therapy to try and address that, and try and address sort of some of the dynamics within relationship to be effective. So, yeah, very good question. And I think, I would totally agree if it's your thought that that is a really important thing to address.
También quieren saber si tú conoces alguna evidencia respecto a los tratamientos psicodinámicos para el trastorno de estrés postraumático complejo.
Yes, so there is no good evidence. There are no randomized controlled trials at the moment that have used psychodynamic therapy for complex PTSD. And indeed, for PTSD, when we looked at all interventions, then there's no randomized controlled trials that we can actually put our hat on to recommend it from. There were some very early trials. There's one from somebody called Brom in the Netherlands, going back into the 80s, that did seem to indicate some positive impact of a time-limited, a sort of 16-session focused psychodynamic approach, but there is no evidence. So I think the old, the old mantra of absence of evidence doesn't mean evidence that these aren't going to be effective is true. But I'm certainly a great believer that we should be striving to get evidence for things. And at the moment, because we've got good evidence that certain interventions, for example, the cognitive behavioral therapy with the trauma-focused interventions have got good evidence, we should be offering people those as their first-line choice. Now that said, I find actually particularly attachment theory really, really helpful in understanding and trying to treat people with complex PTSD. And I think when you look at where dialectic behavior therapy has come from, then there's obviously an awful lot of attachment theory that goes into that. So people like, I suspect you probably will know this person, but John Bowlby, who's was somebody from the United Kingdom who did a lot of work on attachment going back many years. A lot of his writings make a lot of sense to me, and I definitely use them to help me with my formulations of people and also my approach to people in terms of understanding attachments, that have occurred throughout life with different people and are also probably occurring with me as a therapist now.
Ok. Y una última pregunta relacionada a... Hay muchas preguntas súper interesantes todas. Lamento que no tengamos más tiempo para discutirlas. Una última pregunta respecto al tratamiento farmacológico. ¿Sí? Tiene dos partes la pregunta. ¿Qué tratamiento farmacológico se recomienda para trastorno estrés postraumático simple y trastorno estrés postraumático complejo? ¿Hay diferencias? Y la otra pregunta es, pacientes que están tomando benzodiazepinas, ¿en qué momento deberían empezar el tratamiento de estrés postraumático, EMDR o terapia cognitiva? It's 2 questions.
Yeah, no, they're good questions as well. So with complex PTSD, just like for psychological treatments, there isn't an evidence-based to go from, so we need to make informed decisions. And so I think that using the evidence for PTSD on its own is a good starting point, because that should inform what we would do for people with more complex difficulties. And don't forget that a lot of the research that's been done for pharmacological treatments for PTSD has been for treatments of people with PTSD to quite complex events. And I'm sure a lot of them would have had complex PTSD if we'd have made a diagnosis at the time they started in a trial. So the first line treatments are the selective serotonin reuptake inhibitors, fluoxetine, paroxetine, and sertraline, along with the serotonin and noradrenaline reuptake inhibitor, venlafaxine. There's good evidence that they can reduce symptoms of PTSD in people, and I tend to use those for people with both PTSD and complex PTSD. My second line treatments for people, well, I'll probably go SSRI first and then venlafaxine second, but my second line treatments would include adding in more calming drugs, which I think probably you're likely to need more for people with PTSD. And there's good evidence for some antipsychotic drugs. Personally, I tend to favor using quetiapine because I find that that has less side effects than other drugs with an evidence base, such as risperidone, but that risperidone would be equally a fair thing to use. And also praxazine, which isn't an antipsychotic, it's an adrenergic blocker. It sort of, it reduces the levels of noradrenaline in the system. That's another drug that I often use in conjunction with one of the SSRIs, and I do find helps to calm people down a bit. So those drugs that I've just mentioned tend to be the main drugs that I'm using for people with both PTSD and with complex PTSD. With complex PTSD, if there's marked hyperarousal and agitation, then I would often introduce something like quetiapine very early on in treatment, because I think people need to have that calming effect quite early on. And trazodone is another drug that I might use in a small dose to help people with sleeping difficulties. Moving on in a related manner to your question about benzodiazepines, well, I try to avoid prescribing benzodiazepines. There's been a big there's a lot of concerns about benzodiazepines and dependence and tolerance on them. Interestingly, I mean, just so everyone knows, there is a lobby amongst, I was reading a paper the other day from a working group within the American Psychiatric Association arguing that we've kind of gone too far the other way against benzos, and that actually controlled use can be quite helpful for some people. All of that said, I tend to avoid them. If somebody is on a benzodiazepine, though, and has been for a long time, it can be very difficult to reduce and bring them off it. So what I would tend to do is not rock the boat too much. And as long as I feel that they're stable enough on their benzodiazepine and they're not sort of like knocked out with it or anything like that, then I would tend to deliver psychological treatment while somebody is on it, rather than necessarily trying to get them to come off it. The argument is that if you do treat somebody who's on a benzodiazepine, you are treating them in a condition where they are on a benzodiazepine, so you don't know what will happen when they reduce and stop it, and their symptoms may come back. But that's clearly a risk that we're taking if people are on other medications as well.
Muchas gracias a todos los participantes, a todas las muy interesantes preguntas. Algunas de ellas las vamos a contestar por chat, sobre todo las relacionadas con el manual. Hay varias preguntas relacionadas con eso. Muchas gracias, John, por esta presentación y por tus claras respuestas a las preguntas. Y los invitamos a poder conectarse a la siguiente conferencia. Muchas gracias a todos y a todas.
Thank you, gracias.